Now, how we diagnose diabetes? First, of course, we do fasting blood sugar. You have an overnight fast after 18 hours. We draw your blood sugar in the morning. If it's above a certain number, then we say, okay, you have diabetes, but we repeat the test again on a different day to confirm it. So one reading is not enough. Or if you have symptoms of diabetes and your sugar is over 200, like you're feeling thirsty, you're going to the bathroom a lot, you're having blurry vision or fatigue, weight loss, these are the symptoms of high blood sugar. And then we check the blood sugar. If it's over 200, then that's enough for us. Or we do the glucose tolerance test. You drink a fixed amount of glucose or sugar, and then we check your sugar before and after. We see how high your sugar goes. And nowadays, approved since December of last year, what we call it A1C. Is a test we do to see how is your sugar controlled over the last few months. And if this is over a certain number, then we say, okay, you have diabetes. The good thing about this test, you don't have to be fasting. You just go at any time of the day, you have the blood draw, and then we can tell. And these are the numbers. So to be normal, your sugar should be below 100. 100 is high. Or below 100 or 2 hours below 140. And the A1C should be below 5.7. Diabetic, 126 or more. Or over 2 hours should be more than 200, or A1C more than 6.4. Anything in between is pre-diabetes. Yes?
Have you seen issues with different problems with hemoglobin in doing the A1C, where different groups of people where it might not be as accurate?
You see, why it took so long now to have an A1C as a diagnostic criteria? Because the lab differs. If you do it in the same blood sample, 2 different labs, you may have slightly 2 different readings.
Right.
And sometimes with an A1C 6.4, you miss some patient with diabetes. But still, it's a cost-effective way of diagnosing patient with diabetes.
But like with sickle cell or something?
I mean, you talk about now different population.
Yeah, different population.
Now, let me explain how A1C is. It's A1C, when you have high blood sugar, it precipitates in your blood cells, the red blood cells. And that precipitation is irreversible process. When you have it, it doesn't go back. So the hemoglobin on the blood cell will change from hemoglobin to glycosylated hemoglobin. That process is irreversible. It doesn't go back. And as we know, the blood cells survive in the blood for about 90 days to 120 days. And that's why we say every 3 months or the last 3 months. Because the blood cells, it takes about 3 to 4 months to die. So in this case, if someone's blood cells die faster, like someone has sickle cell disease, their blood cells die faster because the body consumes them much faster than normal people. Or someone has thalassemia. Or someone has blood transfusion. They've been taking normal blood and they already have blood. So if you put them all together, it can give you falsely low readings. So in this certain population, we cannot really use this. We have to be very careful. Or like someone have what's called microcytic anemia or microcytosis or microcell, small RPCs. It will give you falsely low A1C because the blood cells are supposed to survive for 120 days. Now they're surviving for 60 days. So you will have more new cells than you're supposed to. So this will lower your A1C, yes. In this population, we cannot use it. But I mean, most of the people, we don't have these problems, so it should be not an issue here.
So you're not seeing a lot of those problems?
I have few patients, I don't follow A1C because of this.
Right.
When, like someone renal failure who taking the injection to promote more RBCs production. We cannot really use this only because this can give us false low numbers. And I have some patients who have microcytosis or sickle cell. I don't use it much. I just look at the numbers and compare it together. Any questions about A1C? So now an easy way to do the blood sugar check is just A1C. Don't have to be fasting. And this can tell you if you are belong to normal range or diabetic or pre-diabetic range. So what are the signs and symptoms? It depends if you have type 1 or type 2. If you are a little bit elderly, over the age of 15 or 20, most likely you will have type 2. Every now and then we may have type 1 at older age, but most of the people have type 1 are younger age population. Teenagers or younger. Few months to 10, 15 years. That's what they have it. Within a few days, within a week, they start having all these symptoms. And they're not taken care of right away. They can have coma, or what we call diabetic ketoacidosis. Their sugar become really high. They will have acidosis in the blood, and they can do coma stage. And that's why they diagnosed early. Type 2, you can miss them for many years. And that's the typical scenario. Most patients will have diabetes for years before they even diagnosed. Some symptoms, someone have recurrent yeast infections in females, or abnormal weight gain, or darkening around the neck, under the arm, or between the legs. Start having complications, like affecting the vision, impotence, numbness of the hands and the feet. This could be signs of complication of diabetes. So it's very important to look for it. Don't wait till you have symptoms. Now, how we treat diabetes. If you don't see, with a treatment plan, it's not only treatment, there's a plan for it. It involves too many people here. It's a teamwork. It involves the patient and too many things around them. That's involved. It's you. The most important is the patient. Without the patient following the instruction, we cannot really do anything. We have your primary care, your specialist if you need them, your dietitian, your educator, your eye doctor, foot doctor, dentist. All these usually should be involved in the management of diabetes. Because it's multi-organ, it really needs discipline, patient really need help. They need how to eat, how to exercise, what to do in certain situation, what to look for to prevent problems, and so on. So it's the teamwork. And the most important one in the team is the patient. If the patient is not interested, we cannot do anything. I mean, I have patients in my office, they don't listen to you. So whatever you do, they leave your office, they go to McDonald's, they have 3 burgers. I mean, I go to McDonald's, sometimes I see them there, having the largest size, 1,000 calories. And then after that, they have the sundae or whatever, another 1,000 calories. And they come to your office, they're not losing weight, their sugar is always high. You explain to them, yes, we'll do it. Then you go again, you see them, the same people again there. So it's really the patient is the most important person in the management. And the good thing about it these days, we have no specific diet for diabetics. Just do the right thing. That's it. You'll be okay. Listen to your doctor. Listen to the ladies there. They will help you a lot. I mean, you can't imagine, because sometimes I have resistance from patients to see a dietitian. They tell you, oh, I know all about it. Yes, I know, but I need their help, because they can help. I believe they are half the treatment in the diabetes management, because they can tell the patient what to do, what to eat, how to do it, how to do the math, how to be more consistent in your eating habits, because this is very important. The biggest issue with sugar, the patients are not consistent with the eating. They eat 3 portions of carb in the morning, next day they have 6 portions. And of course, sugar will be up and down, up and down. They have to be more consistent. If they want to lose weight, they can help, they can assess. So it's really dietitian and education is very important, is half the treatment. Because once you know what is diabetes, what you can do about it, management is easy. It's just we have to show the patient what's wrong with them and why we're doing it. So what tests usually we do in diabetic patient? A1C. Usually we do it, as we said here, the blood cells about 120 days, so 3 to 4 months. We should have an A1C test. It tells me how the sugar being controlled over the last 3 months. We should do a urine test once a year or twice a year. We look for proteins in the urine, and the protein in the urine is the first sign of kidney damage. And that we can find out about it way before your kidney starts failing. Cholesterol test should be done twice a year, because in diabetic patients, we treat cholesterol differently than non-diabetic patients. Why is that? Because cholesterol in diabetic patient is different. It's much worse than non-diabetic. The molecule itself is way worse than non-diabetic patients. So someone bad cholesterol 130, in diabetic, as if they have it 190 or 160. It's that bad, their cholesterol. Because I get the question all the time, why my cholesterol is 100? Why are you giving me treatment? Because that 100 for you is like someone is 160 or 150. And that's high. So we need to bring your cholesterol really down. Recommendations for LDL or bad cholesterol, it should be below 100. But if you have a heart disease or if you have high blood pressure, other problems, it should be below 70. Because we know the lower the bad cholesterol, the better for you. Now the good cholesterol or HDL, in men, we like it 40 or over. In women, it should be over 50. Triglyceride, it should be below 150. So your primary target is bad cholesterol below 100 in all diabetics. If your cholesterol is 101, we give you medication to lower your cholesterol below 100, or 30% less than your baseline. So if you came to the doctor, your cholesterol is 99 or 90, we give you medication to make it 60. So it should go down 30% below 100, or 70 if you have other risk factors. So it's very important. Kidney test, liver test, because we know it can affect the kidney, diabetes, so we have to check for the kidney. Why liver test? Because many of these drugs we give, they go through the liver. So we need to check the liver to make sure the liver is okay. So these tests should be done every few months or every year. It depends which one we're talking about. Any questions about testing in diabetics?
How about if the cholesterol is normal range, so to speak, but the triglycerides are really high? You still just, then you're looking at that level to get it down? Or? It
depends. If the triglyceride is over 100, that will be our primary focus now, because we need to bring triglyceride below 150. But if a triglyceride is below 500, what we'll do first is we give them medication to lower their bad cholesterol. Then we look for triglyceride, because this medication or the statins or like, Zocor, Crestor, Lipitor, whatever, it will lower triglyceride. But if it is over 500, you have to give something else for triglyceride first.
So you're treating the cholesterol and the triglycerides fall into place?
Yes, yeah, because triglyceride is part of the cholesterol, but they are not the primary ones.
Right.
Primary one is bad cholesterol, LDL, except if it is over 500, then it will become primary in this case. Now, how often would you check blood sugar at home? Because once you have diabetes, you need to check your sugar at home. That depends. If you take insulin, we recommend every time you eat and you take insulin, you should check your sugar, and then before bedtime. Or what we call QAC and HS, or before each meal and before bedtime. If you are taking oral medications, it depends. If your sugar is well controlled, once a week is enough. If you want to have more glucose, once or twice a week should be fine. But if you take insulin, it should be much more frequent. And don't overdo it. Overdoing it, it makes things worse actually. Because patients become obsessed with the sugar, they start taking extra insulin, they become having more problems. So 4 to 5 times a day at most is enough, except in very few cases. Now, that's your targets. These are general numbers, but it varies from patient to patient. If someone is 20 years old, it's different from someone is 90 years old. Because the older you get, the more likely you have other issues, and the more likely low sugar is more serious with you. So these numbers are good for someone at 20, 30, 40, 50, or even 60 have no issues. If someone is 80 years old and there is a risk of fall or risk of heart disease, I will not go so tight with them, because there is a risk of low sugar can do more harm to them. So these are general rules. So remember, 100, 180, A1C 7. Because I get them time, I'm sure you get the same thing. 180 is too high. And patients start calling you after the 82, sugar is too high. But that's the target, 180.